real life.
Good evening, all respected doctors. And on behalf of Kedla Pharmaceuticals Limited, I am Hiren Jotania from Head Office Ahmedabad. Welcome all of you for today's scientific event on Bempedoic acid. I am very fortunate to introduce our today's eminent speaker, Dr. J.C. Mohan from Delhi. He is well-known cardiologist from Delhi. I will take privilege to introduce sir. Dr. J.C. Mohan is the president of the FX Society of CM in Cardiology. Dr. J.C. Mohan formerly as a professor in cardiology at the GB Pant Postgraduate Institute and Medical Education Research at Delhi from 1984 to 2003. Sir has been chief of cardiology at various hospitals like Saroj Super Specialty Hospital, Metro Heart Institute, Sundarlal Jain Hospital, and Fortis Hospital at Shalimar Bagh. Sir's area of interest are heart failure, valvular heart disease, hypertension, and interventional cardiology. Sir has published 250 plus research paper in various index journals and only honorary fellow of American Society of Echocardiography in India. Sir has served as a president of the Indian Academy of Echocardiography, the president of Cardiology Society of India, and as a vice president of Cardiology Society of India. Sir, we are very much fortunate to have you on board today, sir. And for further proceeding now, I will hand over the session to you.
Should I start?
Yes, sir.
Yes, sir.
Thank you, Harshad. Thank you, Hiren. And good evening, ladies and gentlemen. Welcome to this webinar focusing on bempedoic acid. But we would talk in general about how should the LDL cholesterol targets be achieved in populations at risk, what are the caveats, what are the issues, and what are the challenges. Proportionate mortality from cardiovascular disease in India is on the rise. The graph of last 25 years shows a progressive increase in cardiovascular disease, both in men and women, slightly higher in men than in women, and currently it is believed that 31% of all deaths in adults are as a result of cardiovascular disease. More worrisome is the fact that the graph is ascending, and it has been estimated that by 2030, 36% of all adult deaths would be as a result of cardiovascular causes. Of the cardiovascular diseases, atherosclerotic cardiovascular disease accounts for 87% of all cardiovascular deaths in India. It is true for the entire Asia, Central Asia, Western Asia, Eastern Asia, and Southern Eastern Asia. So we have to focus on atherosclerotic cardiovascular disease, which is a generalized chronic inflammatory disease of the arterial system. The atherosclerotic vascular disease is very common in the community. It has a long latent period. The atheromatous plaques start developing right in adolescent age, but there is a good amount of period during which no event takes place, and we'll call this period latent period. This latent period is the window for preventive actions, essentially what we call as primary prevention. And once a vascular event has taken place, as the red line shows, you call whatever actions you take during this time to prevent complications of atherosclerotic cardiovascular disease and its progression, secondary prevention. So we have talked about the natural history of atherosclerotic cardiovascular disease. The issue is how common is atherosclerotic cardiovascular disease in the community. So this is data from a study called PISA, Progression of Early Subclinical Atherosclerosis, and this is from Spain. So the study has consecutively used 3D and 2D ultrasound and coronary artery calcium scoring in young, relatively young bankers from Santander Bank, Madrid. And the essential part is mean age of these people was 45 years of age, and they mostly had very low, they had mostly ideal health scores. They were low risk individuals. So what did the study find in these individuals? 2/3 of them had evidence of atherosclerosis. Remember, the age is just 45 years. Low risk individual, healthy bankers. 44% had evidence of atherosclerosis in 2 or more sites. Coronary calcification, which tells you about extent of coronary atherosclerosis, was present in 19% of these individuals. So you can understand that world over, atherosclerosis by the age of 45 years is so much prevalent that preventing vascular disease in population should be the topmost healthcare priority all over the world, particularly in India, because we develop atherosclerotic cardiovascular disease at a younger age. We develop a much more malignant disease, and we have much higher morbidity and mortality. So how can we manage atherosclerotic cardiovascular disease? The holistic ways of managing atherosclerotic cardiovascular disease are targeting dominant components, that is glycemic control, because a large number of these people are diabetic, blood pressure control, LDL management, that is an essential part of the story. And the reason is population attributable risk because of the LDL cholesterol is 50 to 65%. And then, of course, therapeutic lifestyle modifications, focusing on diet, exercise, cessation of smoking, control of weight, and so on and so forth. In all these 4 domains, there is something which is preferential therapy and something which is essential therapy. But we will be talking about prevention essential therapy, focusing on LDL management, because this is a dominant risk factor for atherosclerotic cardiovascular disease. So I was saying that the 2 broadband markers playing a role in atherosclerotic cardiovascular disease are dyslipidemia and inflammation. And both are bridged by multiple risk factors like diabetes, hypertension, smoking, obesity, genetic factors, and so on. Both are atherogenic and thrombogenic. Deleterious bioactive lipids have been the main target of prevention of atherosclerotic cardiovascular disease and preventing its complications. But before we come to in detail about LDL cholesterol lowering, a few basic facts need to be understood. Every cell can synthesize cholesterol, and no cell has an absolute requirement from cholesterol uptake from outside. Therefore, plasma LDL concentrations can be extremely low with few adverse effects. This point is important for us to remember, but we also have to understand that free cholesterol is toxic to human cells because human cells cannot degrade cholesterol molecules. I will let you know why I have made these 3 statements. Anyhow, the point is that most of the cholesterol is carried by by the low density lipoprotein particles called LDL. So LDL cholesterol, the particles are essentially having much more cholesterol ester, a bit of free cholesterol, a carrier protein called ApoB100, some phospholipid, and very little triglycerides. What do LDL cholesterol particles do? They go across the endothelium, the arterial subintima, and then they, of course, come back. But sometimes they get stuck in the subintimal region, and these will produce atheroma. So LDL is involved in every step of atherosclerosis, be it endothelial dysfunction, be it fatty acid streaks, or even obstructive atherosclerotic disease at the end. any part of the spectrum you look at as far as vascular disease is concerned, LDL has a role to play. And hence, reducing LDL, controlling LDL is essential for prevention of vascular disease. From where does the LDL cholesterol come? Remember, as I said, that nearly 60% of the cholesterol is contained in LDL cholesterol. It's a circulating particle. Its sources are intravascular lipolytic pathways in the vasculature, on the surface of the vasculature, hepatic lipolytic pathways, direct hepatic LDL cholesterol synthesis, and of course, lipid transfer pathway, CTAP and CCAT pathways, through which actually VLDL and intermediate density lipoproteins get converted into LDL cholesterol. What is a LDL particle? LDL is an informative biomarker. What information does it provide to us? Well, it's a major risk factor for atherosclerosis. Its target, its plasma level target, is risk dependent. Relative risk reduction relates to absolute LDL reduction. Lower is better, but lower is safer. So the point which you have to emphasize is that not only lower is better, lower is safer. We also have to keep in mind that the LDL exposure has multiplicative and cumulative effects, and also there is marked variation in physicochemical and metabolic profile of LDL particles, and hence the same particle may be less atherogenic in some or could be more atherogenic in others because of these changing physicochemical properties. If an example would be a small dense LDL particle which has actually much less phospholipids and triglycerides, is much more atherogenic. Glycated LDL is much more atherogenic. Oxidized LDL is much more atherogenic, and LDL particle which has free cholesterol is much more atherogenic. So the physicochemical properties also decide the atherogenicity of the LDL. The other point which you have to remember is the LDL has been shown to be associated with relative risk of coronary heart disease in multiple different ways. We have Mendelian randomization studies which have shown that if we have genes which give us more or less LDL cholesterol, so would vary our risk of coronary heart disease. An absolutely linear risk. So if you are born blessed with genes by virtue of which you have lower LDL cholesterol, your risk of developing coronary heart disease is much, much lower. Similarly, we have shown data from prospective cohort studies like Framingham study, ProCam study, the atherosclerotic research in community studies, MESA study, strong heart study. All studies have shown that higher is the LDL cholesterol and also total cholesterol, higher is the relative risk of coronary heart disease. And at the end, we have in the red lines show you randomized control trials wherein we have shown that whether these are secondary prevention trials or primary prevention trials, any which way you look at it, lower is the LDL cholesterol, lower is the relative risk of coronary heart disease. So what should be the target of LDL cholesterol? The new guidelines suggest, the American guidelines are a little simpler compared to European guidelines. American guidelines say that clinical atherosclerotic cardiovascular disease, your target should be LDL more than 50% reduction from baseline, and finally target achieved should be less than 70 milligram per deciliter. Ideally, you should achieve both. Not only the final figure should be less than 70, but from baseline, you should reduce LDL by more than 50%. And this is based on solid data. The European guidelines, which were in 2019, and then preventive guidelines in 2021, have the same message. People with atherosclerotic cardiovascular disease or at very high risk, LDL cholesterol target is less than 55 milligram. In high-risk individuals who don't have atherosclerotic cardiovascular disease, but who have 3 or more risk factors or 10-year risk is more than 10%, or they have diabetes with one risk factor, all these individuals fall in high-risk category, and people with an EGFR between 30 and 60 they all fall in a high risk category, and there the target should be less than 70 milligram. We do have recommendations for Lipid Association of India. Those are a little more stringent, and if time permits, we'll discuss that part also. But I need to emphasize again that atherogenic potential and vascular toxicity of LDL cholesterol is higher in Indians, as shown in inter-heart study. Probably it is augmented by inflammation and insulin resistance. So typically Indians have particle subclasses with elevated atherogenic potential. And this is something which we need to keep in mind. We have data from ICM and India study telling us the kind of Indian dyslipidemia pattern actually results in more pro-atherogenic LDL cholesterol, although the LDL cholesterol level is not very different from the Western world, but it is marked by low HDL and of course high triglycerides. I was telling you that we do have 2020 guidelines from Lipid Association of India, which are little more stringent. And I have also been one of the co-authors of these guidelines. These guidelines suggest that for atherosclerotic cardiovascular disease, our aim, our target should be less than 50 milligram. But people who are very high risk, recurrent acute coronary syndrome less than 12 months, polyvascular disease, diabetes with atherosclerotic cardiovascular disease, the optional target should be below 30 milligram. It is easy to define targets, it is easy to fix targets. That we don't achieve these targets in vast majority of patients is another story, and we would be discussing that story. So how do we lower LDL cholesterol? We of course have large number of agents available with us. The story started with the bile acid sequestrant, but we will actually look at them by the way the mechanism of action. The synthesis inhibitors are statins and bempedoic acid. The drugs which decrease the absorption of cholesterol from the enterocytes are ezetimibe and bile acid sequestrants. Pathway modulators working on lipoprotein lipase or PPAR gamma or niacin fibrates and saroglitazar. And we have PCSK9 inhibitors, monoclonal antibodies, as well as small interfering RNAs, plus many oral PCSK inhibitors being developed. And we are also developing NG-PLAT4 blockers and many other monoclonal antibodies working on LP little a and so on and so forth. These are all agents which can lower LDL cholesterol. But remember, the randomized trials with niacin and fibrates have been negative. The positive trial have been with ezetimibe, statins, and bile acid sequestrant and PCSK9 inhibitors. How else we can reduce LDL cholesterol besides statin, ezetimibe, and bempedoic acid? Well, we have gene silencing, we have peptide mimetics, we have small molecule inhibitors, and we have monoclonal antibodies. These are all monoclonal antibodies are available in market. The others we are waiting, although trials have been done. These are going to be expensive. These are going to be subcutaneous. These are going to be actually not expensive, super expensive in some instances. We will spend some time in talking about statins. Statins are great drugs. We have been using it now for a long, long time. And I remember the first time I actually prescribed lovastatin was somewhere in 93 or so. So 30 years back, actually, I started using statin. Statins reduce hepatic cholesterol synthesis. These also actually cause upregulation of LDL receptors. So by these two ways, LDL cholesterol lowered by statin. High intensity statin lower LDL by 50%, moderate intensity anything from 30 to 50%. Good. That is so far very good. What is downside of statin besides pro-diabetogenicity, which we wouldn't talk of? The increased intestinal absorption of cholesterol. Whenever you use statin, there is a compensatory increased absorption of cholesterol, and there is increased PCSK9, which in turn causes degradation of LDL receptors. So over a period of time, statin lose some of its efficacy because of the last two two effects, and we need to keep in mind that is one part of the story with regard to statins, but the other part is large inter-individual variation in response to statin therapy. It has several mechanisms. Besides the four mechanisms I just showed you, there are many more mechanisms which account for large inter-individual variation, and many people just would lower their LDL by 20% even in the high-intensity statin therapy. You could call them hypo-responders. The other part of the story with statins is because statins have been associated with myalgia, perceived or actual, the fact is 50% patients discontinue their statin within 2 years. So here is a large study of 500,000 patients looking at, and this is from the administrative database from United States, looking at the discontinuation rates of statin over a period of time. By 5 years, only 25% of all people prescribed statins are taking statins. But by 21 months, 50% have already discontinued. And that is a sad story. Drugs which are so powerful in reducing vascular events and preventing progression of atherosclerotic vascular disease are used so less by the general public. And of course, myalgias and other perceived side effects like increased chance of new onset diabetes are there. And although they are not very big, but in general physician's mind, these are big factors. The Europeans just actually, Dr. Kaushik Ray looked at the European Union attaining the risk-based goals of the LDL cholesterol. He called it Da Vinci study, large number of patients, large number of countries. What he found was only 33% of the patients were at goals prescribed by ESC in 2019. Those who were prescribed LDL lowering therapy. What was more interesting was that the current status in Europe is such that only 22% people achieve the targets with high intensity statin therapy. Mind it, 22% only. That tells you that you may like statins, you may be in love with statins, but if it is a question of attaining the targets, in Europe, at least only 22% people achieve target with high intensity statin therapy. Statin plus other therapy also does not do pretty well. Now, when you give high intensity statin, other therapy, obviously you probably will lower the statin dose a little bit. Only 19% of all who are will achieve the desired targets. What about combining statin with STMI? Well, STMI is a potentiator of statin, but even then, 37% of all people in Da Vinci study achieved the desired targets set by ESC in 2019. What about using PCSK9 inhibitors, evolocumab or alirocumab? Well, even with that, 58% achieved the desired goal. Still, despite PCSK9 inhibitors being so powerful LDL lowering agents, along with statin therapy, there were a good number of patients, 42%, who did not achieve targets. This could be because maybe PCSK9 inhibitors over a period of time are not that effective as they are touted. That could be one reason. The other reason could be, of course, people instead of taking twice a month, could be taking once a month, or maybe in between dropping because of the cost or because of the pain of the injection, multiple reasons. But we need to keep in mind that guidelines which are lowered LDL targets have sound scientific basis based upon evidence. We can't say that the guidelines are impractical. Guidelines are practical based upon the sound evidence. With lowering of threshold LDL cholesterol, goal attainment is becoming more and more difficult. I showed you typical Da Vinci study, but a similar study is also available from United States with almost similar kind of results. So I don't want to actually belabor with a lot of studies. I want to give a message that most people don't achieve the desired target. And large unmet need for more powerful LDL lowering drugs or combo. Now that is important. Since people are not achieving the targets, you have to look at more drugs which can lower LDL cholesterol, either to be used in isolation or in combination. And that way, more patient can attain the target set for them. So that was the preamble. Now we talked about drugs. With the new drug, new kid on the block, which has been introduced to Indian market, is Bempedoic acid. Bempedoic acid is an oral agent. It is once a day dose, and it is pretty effective LDL lowering agent. But let's talk about this. Essentially is a cholesterol biosynthesis pathway inhibitor. So is statin, as I told, but it is a upstream inhibitor, and statin is a downstream inhibitor of cholesterol synthesis. It's a small molecule fatty acid. It is a decoy molecule for citric acid cycle, and it actually, there is a step in which citric acid converted to acetyl coenzyme A with the help of ATP citrate lyase enzyme, which is inhibited by bempedoic acid. Bempedoic acid also stimulates AMP activated protein kinase, and this actually has multiple actions. Besides diverting acetyl coenzyme A to another pathway rather than cholesterol synthesis, it also improves the tissue glucose uptake and insulin sensitivity. Also, the AMP activated protein kinase stimulator actually inhibits indirectly HMG coenzyme reductase. So let's again look at the Krebs cycle and the oxidative, the glycolytic pathway in the simplest possible form. You actually convert glucose to pyruvic acid in glycolytic in glucose oxidation pathway produced from 6 molecules of ATP from 1 molecule of glucose. Then pyruvate gets converted into active acetate, and the Krebs cycle or citric acid cycle starts. The active acetate gets converted to oxaloacetate, then to citrate, and citrate needs to be converted to acetyl coenzyme A with the help of this ATP citrate lyase. This is inhibited by bempedoic acid. The next step, of course, is the mevalonic acid, which is synthesis, which is of course blocked by statin, and then mevalonic acid gets converted into cholesterol. So all I am saying is bempedoic acid is an upstream inhibitor of cholesterol synthesis, while HMG coenzyme reductase inhibitor statin is a downstream inhibitor of cholesterol synthesis. Both have synergy, and we need to keep in mind that if we can't give one, we certainly can give other, and in large number of patients we can give both drugs for better LDL cholesterol lowering. The AMP activated protein kinase is a multi-substance protein kinase that in liver inactivates 3-hydroxy-3-methylglutarate coenzyme reductase also, which is the rate limiting enzyme of cholesterol synthesis. So you would see that the active acetate getting converted to mevalonic acid needs HMG coenzyme reductase, and this thing is promoted by HMG coenzyme reductase. That is why that is inhibited by statin, but it is actually inhibited by AMP activated protein kinase, and this is stimulated by bempedoic acid. End result is much less mevalonic acid, much less cholesterol synthesis. Okay, so what is the efficacy of bempedoic acid? And here is an interesting data, and this is a very recent data of April 2022, coming from Germany. Statin naive patients, when you give bempedoic acid 180 milligram per day, there is a 25% reduction in LDL cholesterol. If you give it on top of statin, you have 18% reduction in LDL cholesterol. If you give estimide plus bempedoic acid in statin naive patients, you can achieve as much as 45% reduction in LDL cholesterol in 12 weeks. But if you give on top of statin, estimide, and bempedoic acid, you have 35% reduction in LDL cholesterol. Now, why is this data important? The data is important because when you give estimide plus bempedoic acid in statin naive patient, 45% reduction is almost near what we want to achieve in individuals who is statin. So if the patient is statin intolerant, or you can't give statin for whatever reasons, the other best thing actually to get statin-like effect is combination of bempedoic acid and ezetimibe. Okay. However, we do have actually much larger data of fixed dose combination of bempedoic acid with ezetimibe or placebo or ezetimibe alone or bempedoic acid alone. in patients who tolerate maximum dose of statin. And now we are talking individuals who are tolerating the maximum dose of statin. Here, bempedoic acid causes 20% reduction in LDL cholesterol, additional estimate 24%. Remember, estimate is slightly more effective or maybe equally effective, and combination of bempedoic acid and estimate 35% reduction in LDL cholesterol. There have been 4 studies, large studies, using bempedoic acid. 2 of these studies are on patients who are on full dose of statin. Those are shown in blue circles. Maximally tolerated statin background therapy. The 2 studies are Clear Harmony and Clear Wisdom. The other 2 studies are where statins were not on board. These are shown in orange color. These are called Clear Serenity and Clear Tranquility. Now, they are all patients who have atherosclerotic cardiovascular disease or heterogeneous familial hypercholesterolemia. All 4 studies have one aim: to show safety and efficacy. These are not outcome studies. So let us look at the efficacy first, LDL lowering efficacy. If patients are already on maximum tolerated statin therapy, then you have about 15 to 16% reduction in LDL cholesterol. Remember, these are randomized studies. And if patients are statin naive, you get about 24% reduction in LDL cholesterol. So that is 12-week study. So LDL cholesterol reduction is anything from 17 to 28.5%. But if you correct this whole thing against the placebo, then you find that the benefit is 28% statin naive patients and 18% in patients who are all on maximally tolerated dose of statin. There is another benefit of bempedoic acid. It is also an anti-inflammatory compound. People who are already on maximum tolerated statin therapy, there is a further 20% reduction in high sensitive CRP, as shown in the left half of the graph. And those who are not able to tolerate statins, there you have about 30% reduction in Clear Tranquility and 25% reduction in the Clear Serenity study. So obviously, the drug is also an anti-inflammatory drug like statin, and that is a big, big advantage. Synopsis of Clear studies say that other parts of the dyslipidemia, total cholesterol, ApoB, and non-HDL are also reduced significantly. More in statin naive patients, as shown in green bars, the light green bars, and on top of statin in dark green bars, and those are little less. Nevertheless, every component of bioactive deleterious dyslipidemia is reduced significantly by bempedoic acid. But you might say, well, that is good, but we have data from as well as improved studies concerned with estimate. What about bempedoic acid? Well, for bempedoic acid, the outcome data of a large number of patients, 14,000 studies going on, and we hope to see the results of this trial early next year. And these are all people who are either history of atherosclerotic cardiovascular disease, and these people are those who have statin intolerance or LDL is above 100 milligram despite being on statin. So we are going to see what happens to these individuals with regard to 3-point MACE or coronary vascular. So this is a 4-point MACE. It includes cardiovascular death, non-fatal MI, non-fatal stroke, and coronary vascularization. So we are awaiting outcome data, but there is no reason to think that the outcome data wouldn't be positive. The drug actually has multiple beneficial metabolic effects besides LDL cholesterol lowering, hsCRP lowering, and of course, improving insulin sensitivity. So what are the adverse effects seen in Clear studies? There is a slight increase in serum uric acid, little more urinary tract infection, more muscle spasm, back and neck pains, little bit elevated the liver function test, and risk of tendon rupture. So we need to keep in mind that people who actually have a chance to, because tendonitis or something, who have risk of tendon rupture, we have to be careful. So here is the data from Clear trials. The chance of developing the rise in liver enzymes is there. There isn't any doubt about it. Blood creatinine levels, there is a There is not much chance, but the blood uric acid level, there is a chance, statistically significant chance of increasing it, and there can be slightly high chance of creatine kinase rise. Studying naive patients on bempedoic acid, well, you can see the LDL cholesterol lowering, which can be 27% of bempedoic acid, 39% STMI plus bempedoic acid combination. Incidence of muscular side effects with bempedoic acid shown in red letters on the right side is similar, whether the patients are on bempedoic acid alone or bempedoic acid plus STMI. Muscle side effects don't exist with bempedoic acid. The bempedoic acid, we talked about the high sensitive CRP. We will skip this part. What about new onset diabetes? Because that is an issue as far as statins are concerned. So meta-analysis of 4 clear studies have shown that there is 30% less chance of new onset diabetes with bempedoic acid compared to statins. Statistically significant, but keep in mind that these studies were not designed to look at new onset diabetes. This is just a byproduct of those studies. So we need to study it. If the drug is that powerful in reducing new onset diabetes, maybe it will find place in patients with pre-diabetes treatment. I talked about safety concerns. Of course, renal impairment, there are no safety concerns. There is a very recent data by George Beckeris presented in American College of Cardiology meeting exactly 7 weeks from now. It was presented. The efficacy was similar and safety was similar regardless of the eGFR. Hepatic impairment, no dose adjustment required. And in all patients, you have to assess uric acid, past history of gout, because there is more chance of uric acid, more chance of gout. And if people are taking corticosteroids or fluoroquinolones or with renal failure, there's a little high chance of tendon rupture. Who should not be taking this drug? People who are on simvastatin or pravastatin, those more than 20 and 40 milligram, pregnant women, breastfeeding women, and patients who are a high chance of tendon rupture. So these are some of the contraindications which we have to keep in mind. I did talk to you that in renally impaired patient, bempedoic acid can be safely given. This is the paper presented by George Beckeris and his colleagues from Chicago, 6 weeks back in American College of Cardiology. Large number of data, and again, the data is derived from 3 studies, and the data suggests that safety is established. And there is similar efficacy in really impaired patient, whether the patient have stage 2 CKD, stage 3 CKD, or stage 4 CKD. So how do we try to achieve the LDL cholesterol goal? See, if you look at this Odyssey option 1 study, it says that when you double the dose at atorvastatin, you get another 6% reduction in LDL. You add STMI, you get 18% more reduction in LDL. You change it to rosuvastatin, you have 20% more reduction in LDL. Remember, rosuvastatin is more powerful than atorvastatin, and we do agree. But the other thing is you can give evolocumab, and there is a 60% additional reduction in LDL cholesterol. What else you can do? Because evolocumab is being used, even in Da Vinci study, it was being used in 1% of the entire population. The STMI was being used in 9% of the entire population. What else you can do? One thing you can do is add bempedoid, which is equally effective as STMI, synergistic to STMI, and produces a double benefit, something like 45% in statin naive patients. What else you can do? You can give a combination of bempedoic acid, STMI, when that will produce close to a 40% reduction in LDL cholesterol, 45% in statin naive patients, 35% in maximum dose, tolerated dose of statin, and a great drug which, and you could find reasons where if patients are statin hyporesponder, the 2 drug can be given. If statins are, if the patient are normal responder, you can give either of the 2 drug, depending on the tolerance and of course the cost. And in statin naive and statin intolerant patient, the combination would be a great choice. So there are many sutras which are trying to woo the statin, and this is a polygamy galore, but STMI, PCSK9 inhibitor, bempedoic acid stand out. These are the ones which are available at the moment. STMI and bempedoic acid both are inexpensive drugs. They actually, bempedoic acid has a great advantage of reducing new onset diabetes, which ezetimibe doesn't have. Cost of ezetimibe and bempedoic acid is same. They are synergistic. So you can either combine the two, give in isolation with statin or without statin in case patients are statin intolerant. So let me actually summarize what we have talked about bempedoic acid in targeted population. Bempedoic acid lowers LDL cholesterol by 20%, and it should be used as an adjuvant to diet and statin. We don't recommend it to be used without the statin unless the patient is statin intolerant. It's an alternative to statin in combination with ezetimibe. It has an anti-inflammatory action. It improves insulin sensitivity by increasing the glucose entry in the cells, working on GLUT1 to GLUT4 enzymes through the AMP activated protein kinase. There are studies going on in non-alcoholic fatty liver disease. There are studies going on whether bempedoic acid can be used for ectopic fat loss or visceral fat loss, not the total fat loss. There are data to suggest actually that the visceral fat can be actually mobilized. So there's interesting data, more so in animals, but we expect something will come out of the human studies also. And as I said, we have clear outcome study going on, and in first quarter of 2023, we'll have cardiovascular outcome data. So this is all I had to say about bempedoic acid. Thank you very much, and I will be happy to take some questions on that.
Thank you so much. Thank you very much. Thank you. Am I audible? Thank you so much, Dr.
You are muted. Again, you got muted.
Yeah, hi. So thank you so much, Dr. Jesse Mohan, for that wonderful deliberation. And now we do have some questions from the viewers. So I would read out these questions for you.
Yeah.
There is two questions. The one on the pharmacokinetics, and the second one is the safety parameters. So I will club the question. The question is from Dr. Sharma. How long does it take for bempedoic acid to work? And the second question is, keeping efficacy and safety in mind, should we believe bempedoic acid is better than statin? Interesting question.
Yeah, I think the first thing, let's talk about pharmacokinetic. The drug is absorbed orally. You can take it with food, without food, before food, after food. It doesn't make a difference, number one. Number two, actually, it has a 60% hepatic clearance, 40% urinary clearance. But keep in mind one thing, that hepatic or renal impairment doesn't make a difference to the efficacy of drug or safety of the drug. That is the second point. The third point is largely protein bound. Fourth, it works on liver. There is no great chance of having gallstones and other things, so bile is not affected. The drug is long acting. 180 milligram tablet would work for a long time. Question is what about using it instead of statin? So I did show you data from George Beckeris. It is safe in renal patients. You can use. What about patients? What about the risk of diabetes? So we have a large amount of data as far as pharmacodynamics are concerned, that the C-peptide levels are lowered, the insulin levels are lowered, the HOMA-R levels are lowered with the drug. We have good amount of data. I did not go through that. The purpose was to say that the drug actually is anti-diabetic to some extent, and unlike statins. So can we replace statin? No. Statins actually cause on an average 50% reduction LDL at high intensity. Bempedoic causes 20%. If it is actually one of the wives of statin, let us say this thing, it can't be really it can't be, you can't say that it is an equal partner of statin in any way. In case you really have the issue of getting the LDL really to the target, you're not able to get it, I would suggest using all three drugs. In fact, Kaushik Ray a few months back came out with an algorithm. It says every single individual atherosclerotic cardiovascular disease start with high intensity statin plus ezetimibe. If the patient don't reach the goal, add bempedoic acid or PCSK9 inhibitor. So interesting concept actually.
So again, the extension of the same question from Dr. Kamal. What if the patient's LDL-C level is less than 100? Can we skip the statin?
I don't think you should skip statins. These statins are proven drug. We have large amount of outcome data. There is ironclad proof of evidence. There is ironclad evidence. In a drug which has been in use for 30 years and we have that kind of ironclad proof, there is no way that you can replace the drug. It's a class 1A indication in prevention in high-risk individuals and in secondary prevention atherosclerotic cardiovascular disease. Bempedoic acid is not a substitute. It is not a replacement therapy. It's an add-on therapy. It's an add-on therapy to statin. And of course, you could expand the line. You could actually use the combination because statins, in a pre-diabetic, the combination of bempedoic and statin is good because statin is a little pro-diabetogenic, bempedoic is anti-diabetogenic, the combination would be good. Patients who don't tolerate statin, there are many people, I know of 2 doctors who can't take even 5 million rosustatin. That would be good to combine the 2 drugs, bempedoic and ezetimibe. Third, people, of course, those who have an LDL below 100 despite statin, they are the right candidate. You can either use sequentially ezetimibe and bempedoic acid or bempedoic acid ezetimibe combined or bempedoic acid alone and try to see if you are reaching the levels. The fact continues to be 100 milligram LDL in atherosclerotic cardiovascular is completely unacceptable. So is it unacceptable in long-standing diabetes with CKD stage 3, familial heterozygous hypercholesterolemia, people with 10-year risk more than 20% using Framingham risk score or Q-RISK-2 score, and individuals who actually have a diabetes with target organ damage.
So next question is, I would say, the most asked question by a physician. At what level should we keep our LDLC?
I actually, having been a co-author of the Lipid Association of India guidelines, I believe that every healthy individual should have an LDL below 100 milligram. We know that European Society of Cardiology says below 116. Our is slightly lower, less than 100 milligram in everybody. We also have stringent guidelines for very high risk in atherosclerotic cardiovascular disease less than 50 milligram. And for people with polyvascular disease and of course, recurrent ACS, we have still stringent guidelines of less than 30 milligram. There are data from Fourier and Odyssey outcome showing that even 5-10 milligram LDL is safe. And as I said in the beginning, and while re-emphasize, most cells can synthesize their own cholesterol. They don't need LDL cholesterol from LDL particles. They don't need much of it. I mean, they do take 20%, 30%, but they don't need it that much as you think. Evolutionary, actually, the cholesterol was coming from liver, but over millions of years, the cells said, we are not going to depend on liver for our cholesterol. We'll synthesize ourselves. So God created genes, nature created genes that now they can produce their own cholesterol and of course build and repair their own cells. However, the past thing stays, and that is you still have circulating cholesterol going on, synthesized in liver. And then of course, as long as LDL receptor are working all right, it is not harming you. Although it does harm in majority of the population simply because this is an evolutionary remnant which is no longer required, but largely not required, but is there.
Okay, so there's a question from Dr. Sharma, Ahmedabad. He said, sir, in your slide, we have seen very few patients have achieved LDLC target, even with combination of ezetimibe.
Yes.
So then what should be our approach to increase this number?
So this actually, this is a real world data in Da Vinci study from Europe, and similar data is available from USA. Major issue is how to make sure that there is compliance and adherence. Number 2, that patients have not down titrated. You are actually looking only at prescription and then saying you have not achieved LDL. I have given 40 milligram rosustatin to one individual. I look at his report after 6 weeks. I say, oh, he has not received LDL. I don't know whether the dose has been down titrated, patient has discontinued for several days, or actually it is a hyporesponder. So any which way you look at it, our first important thing is every person who is a candidate must receive statin. So let's make sure that try to get the adherence rate close to 90%. That is the first aim, whatever be the dose. And the second is, of course, the right kind of dose. And in case the right kind of dose is not working, then as my and bempedoic acid. My gut feeling is the combo probably will obviate the need for PCSK9 inhibitors in large number of patients. We physicians have to take up this challenge. What is wrong with us? So today I saw a lady, she has stent in all 3 arteries. I have myself put in 2016. She has some angina. I repeated an angiogram, minor lesions here and there, and I said, you should be on drugs. She comes back to me, she says, you've written 40 milligram rosuvastatin, but my treating physician says this is just too high a dose, go to 20 milligram, and I'm taking 20 milligram. Now that is because she came out of this. Otherwise, I would say just repeat all. She's on 40 milligram rosuvastatin, she's not achieving the LDL target. These are the issues which we have to keep in mind. But there would be true hyporesponders, and for that newer drugs are coming. Hopefully small interfering RNA, oral PCSK9 inhibitors, many more things are in pipeline. We didn't discuss angioplat 3 and 4 inhibitor, monoclonal antibodies. We didn't discuss many things more which are coming up. And then finally, these small peptides will become available orally, and life will become easier for us. Initially, they will be expensive. They wouldn't be as cheap as bempedoic acid, but once there is a big demand, all companies come up. I mean, who could have thought that bempedoic acid you could get for 24, 25 rupees, but you are getting it. So be hopeful.
Yeah. There's a question from Dr. Prem Punhani. He wants to understand the role of bempedoic acid for TG reduction.
Bempedoic acid actually does cause TG reduction, but it is similar of the same extent as statins. So unless patients, the regular kind of dyslipidemia, about 20% TG reduction, and people who have markedly raised triglyceride about up to 40%. But 40% is the maximum. Most people will have 20% reduction in triglyceride. We know bempedoic acid causes. Remember, this statin and bempedoic acid, the mechanism is same. And from where does the triglyceride come from? The triglyceride come because you haven't used endovascular lipoprotein lipase to unload VLDL and IDL into LDL. So if the bempedoic acid actually is reducing the total cholesterol synthesized, circulating cholesterol will go down, and the need for having more triglyceride in these particles will go down.
Dr. Arvind Pancholi asks, is it going to replace PCSK9 in future?
The combination, yes, in good number, not in everybody. But my feeling is, what will be the number? Maybe 20%, maybe 30%, 40%. I can be optimistic and say, if everybody start taking STMI and bempedoic acid along with statin, we could obviate to a great extent. But I think I can't look into the crystal ball and exactly say how many of them.
Okay, so there is one more question from Dr. Aruna. According to the LAI consensus document, in extreme risk patient, the target LDL-C level is less than 30. Can bempedoic acid reduce to LDL to this particular level after statin intolerant patient or after maximally tolerated statin level?
I'm not too sure, but some patient will achieve it. Some patient will definitely achieve it.
So after that, PCSK9 should be given or not?
Absolutely, we can safely give PCSK9. But wait, maybe better things are coming. Better things are in pipeline. At the moment, if I have to treat my high-risk individuals, I'm going to use statin plus bempedoic acid plus histamine. Then if they don't get control, they can afford, their pocket allows PCSK9 inhibitor. A year down the line, I think new things are coming up. I remain positive about this area. The whole field of lipidology is very dynamic. But the much more important thing is let us use the stuff which is already available with us.
So the question in the same line, sir. What should be our approach after statin? Azithromycin first or bempedoic acid first?
I would say that if it's a pre-diabetic individual, I would use bempedoic acid first. If I have that choice is not there, I can use either of the two. But whichever you use, finally you will end up using both of these after statin. The reason is the targets are too stringent actually to be covered in a vast majority of patients with one drug.
There is two questions regarding safety. I'll merge that question. So can we use bempedoic acid in a patient who are on drug to reduce uric acid? Second question is, can we what are the chances of increasing serum uric acid with bempedoic acid?
So bempedoic acid increases the serum uric acid. Chances of developing gout a little more. Chances of developing hyperuricemia more. The factor is something like 2 to 3 times compared to placebo. Can we use it with uric acid lowering agents? Certainly we can do it. But remember, the drug actually prevents the excretion of uric acid by working at the kidney. And we need to keep that thing in mind. And hence, we can use actually, if bempedoic acid badly needed and we don't have a substitute for it and uric acid is getting raised, I would suggest that we can use actually any of the uric acid lowering agents, preferably allopurinol, because it is safer than the other compounds.
We have many questions, but looking into time, we'll take last question. Sir, your comment on mortality benefit and CV safety of bempedoic acid.
So we don't have data. I already told you clear outcome study we are awaiting. We are already in the end May. I mean, we'll start June. Just you have to wait for 9 more months and you will have the data.
Okay.
Hopefully it will be positive data.
Thank you so much, sir. So thank you so much, Dr. Jesse Mohan, for the wonderful deliberation on relatively a new topic, which is on a bempedoic acid, which is just now entering into the Indian market. So with this we come to an end of the fantastic scientific event, and I would like to thank all the viewers who have joined us live from different parts of the country. And I'm sure all these viewers have found this event informative and worth spending their precious times. Thank you so much again, Dr. Jesse Mohan, and all the viewers. Have a great time, sir.
Thank you.